Hello. We hope you had a nice tea break. And to continue on with our first session for today, I would like to cordially invite the chairperson for this session, Dr. Rasika Gunapala, Senior Consultant Pediatrician at Paediatric Hospital, as well as Chairman of the Specialist Board in Pediatrics. And I would like to also invite to join him our faculty for today, Prof. Suleiman, as well as Prof. Sumambalan as well.
On get it.
All right. Okay. Good afternoon, everyone. And it's thank you very much for the kind introduction, and it's great pleasure to be here in this afternoon. I must thank Jayatri for inviting me to chair this session. Yes, as I mentioned, I'm one of the pediatricians at Paediatric Hospital and have a special interest in rheumatology. Right. Let me first invite our main speaker, Associate Professor Elizabeth Ang. She is a Senior Consultant Paediatric Rheumatology in National University Hospital, Singapore. And she is also Adjunct Associate Professor in the Department of Paediatric and National University of Singapore. Right? So she's going to talk about this, basically the MAS and the HLH. And those are the burning issues for us as a pediatrician also. Most of the time when we get the patient, we are in, almost always we are in touch with the Jayatri, and we are in pins basically. It's very difficult to manage, and then basically it's sort of a multidisciplinary approach. So we'd like to hear your views on this and share your thoughts. So let me invite you to the podium, please.
Hello again. Thank you for the introduction. I love that you said that we are going to address a burning issue, because HLH and MAS is all about fire. This is the outline for my talk, and I'm just going to start with a simple case. I saw 12 years ago, a 9-year-old girl with 2 weeks of fever, rash, arthritis, splenomegaly, generalized lymphadenopathy, and blood results as follows. This is her rash, very light, comes and goes. What's the diagnosis? I'm sure all of you, well, the pediatricians will be able to think of it in big groups. But with regard to this girl, it was really maybe malignancy, maybe systemic JIA, maybe HLH. She definitely fulfilled criteria for SJIA, right? A prolonged rash and arthritis, plus the evanescent, prolonged fever, arthritis, and an evanescent rash with splenomegaly. But something is very atypical about this patient. When a patient has a history and a physical exam that is very inflamed, the girl is on fire, we expect her inflammation markers to be high. But look at her white blood cell count is low. At the very best, it was 4, and in fact, over time, it was reducing. Her hemoglobin was low. This is expected in an inflamed patient. But for someone with 2 weeks of fever, I expect her platelet count to be 300, 400, 500. But it was only about 120, 150. This is atypical and should prompt you to think about other conditions, namely a bone marrow or a blood malignancy, or hemophagocytic lymphohistiocytosis, also known as HLH. So, since this was our 2 differentials for this girl, we did 2 other tests. A bone marrow exam, I'll tell you it showed no blasts, and a ferritin, which came back very high at 16,000. This confirms her diagnosis overall of systemic JIA with macrophage activation syndrome, also known as secondary HLH. So what's in a name? If you are interested in this condition, you would come across names like cytokine storm, HLH, MAS, cytokine release syndrome, sepsis, COVID, MIS-C. Let's talk a little bit about HLH. The historical view was that there was primary and secondary HLH. Primary HLH, we used to think of it as a genetic condition, starting very young, no clear trigger, with an underlying NK cell defect. Whereas secondary HLH would be patients with no genetic defects, starting to present later in life with very clear triggers. But we know now that this is not really the case in the past, and even now it's still helpful to think about it in this way, but I will try to expand the thoughts on this. With regard to secondary HLH, you can think of the triggers in three big groups. 1, rheumatologic, 2, infectious, and 3, malignant. When the trigger is rheumatologic, then the term MAS is often used. Here I provide a table of the common triggers of secondary HLH. On the left would be of interest to the rheumatologist. The most common rheum condition triggering HLH would be systemic JIA, but you can see it in SLE, Kawasaki, and other systemic vasculitides. There are a whole lot of infections that can trigger HLH, and I've listed a few of them here. And of course, the oncologic triggers are as follows. For most of the pediatricians or rheumatologists here, you will probably be facing conditions in the first and second column. Sometimes it is meaningful to think about this in terms of cytokine storm. It refers to a whole family of syndromes marked by hyperinflammation, burning, fire, multi-organ disease. And so this is an umbrella term for all the syndromes associated with hyperinflammation. The main problem is that there's uncontrolled, dysregulated immune activation. And as far as we know for now, I suppose it's easy to think about it as a problem with the T lymphocytes, especially the CD8, and the macrophages that exhibit hemophagocytic activity in the bone marrow. And that's the cause of the pancytopenias. The problem then results in excessive circulating cytokines beyond the expected normal response. That's why the term hyperinflammation. And why do we care? Because it can be fatal. We were made to make inflammation for a good purpose, but when the triggers are gone, they should shut down. The body should stop that inflammation. The problem in cytokine storm is when the inflammation continues unabated. Fire. Now, I don't think anymore of HLH as primary or secondary, 1 or 2, because the spectrum of inflammation is variable. In fact, those of you who manage patients in the ICU or the ward can even sense that a patient with sepsis is very inflamed. That would be one end of the spectrum, and increasing in severity you got to patients with primary HLH, but there are overlaps. Let's talk about how we diagnose HLH or MAS. Now, when people think about HLH, they think about diagnostic criteria, and I suppose the latest one would be the HLH 2004, where they use that in a trial to try and group patients together to study. I'd like to say that these criteria were created for a clinical trial on treatment, and they have limitations as follows. The problem is that this criteria is more reliable for primary than secondary HLH. There is no single criteria that's pathognomonic. In this criteria, the ferritin cutoff is 500. And that's not very high, especially for some of you who treat patients with sepsis, inflammation, or SJIA. They easily reach ferritins of more than 500. In this criteria, one of the criterion is hemophagocytosis in the bone marrow, but this has poor sensitivity and specificity. And finally, in this 2004 criteria, they mentioned lab tests that are not easily available, like the soluble CD25 and measurement of NK cell activity. So overall, not very helpful for clinical settings that we are in. As a result, people have come up with a whole lot of other classification tools for HLH and MAS. Again, I put it very small on purpose, because what I want to say is that there are limitations to all these criteria. They are not applicable to every situation. They lack specificity and sensitivity, especially when the patients in front of you have other reasons for inflammation like sepsis. In fact, a careful clinician who can recognize HLH in its many forms is more valuable, because we are treating patients and a process that they are going through. We're not treating machines. Again, I want to quote another pediatric rheumatologist who said, "I don't remember all the criteria. I think my clinical judgment is better than the criteria." Please don't go away thinking that all of us pediatric rheumatologists are so haughty. In fact, take this as an encouragement. For those of you who cannot memorize criteria, it's okay. So let's talk about how to smell the fire before you see it, right? We're trying to smell the burn of a matchstick before it becomes a big forest fire. Here are some clues to HLH, MAS, or cytokine storm. To me, it doesn't really matter what you call it. The patient is often acutely unwell with features not characteristic of the course of the disease in question. This is very important, and this is why it's also very important as a clinician to develop a feel for the patient. The fever is often high and unremitting. There may be organ dysfunction, usually in the liver more than in the kidney, and if very severe, the child may have features of shock and capillary leak. For patients with existing rheumatologic conditions, what we as clinicians need to notice is a change in the lab parameters as the first indication of MAS. I tell you a story of a kid with SJIA that I used to look after. He's doing very well now. He was on treatment for SJIA. One day he had a fever, and he came to the children's emergency. And of course, the doctors there did lab tests, and they called me and they said, "He's improving. His platelets are usually 450, now they're 300. His white blood cell is usually 12, now it's 4. And I said, uh-oh, there's a problem. And the problem is that this is an unwell patient with features not characteristic of the course in question, meaning what I expect in an SJIA patient who is still under treatment, maybe slightly high inflammation markers, now they are dropping. That's the first clue. I want to make one slide or talk about one slide on CNS HLH. This one's difficult. The signs and symptoms can be non-specific, like seizures, irritability, reduced conscious level, meningism, or focal neurological signs. The clues could be in the lumbar puncture, where there is pleocytosis, increased protein. Maybe you can see hemophagocytosis, but again, not specific and difficult to find in the CSF. And if you did an MRI with gadolinium, there would be multifocal bilateral abnormalities on the T2-weighted images that are often symmetric. The difficult thing about CNS HLH is that it can occur without systemic inflammation. So consider it in a child with CNS inflammation without a clear cause. I think if anything, I hope that what you take back from this talk is that you start thinking about it early. Let's say you're thinking about it. I think this is HLH. What do I test? Well, thankfully, the tests are quite simple. On the left, a full blood count, because in HLH, you will get cytopenias or unexpectedly normal white blood cell and platelet counts. A liver function test will reveal raised SGOT, SGPT. And here's another clue. The ESR in an inflamed patient will actually be low or dropping. Ferritin in HLH is very high. There may be evidence of DIC, hypertriglyceridemia. Often the patients in ICU may be very sick with bloated abdomens. If you cannot find or feel or palpate hepatosplenomegaly, do an ultrasound. Bone marrow studies, I know, are available easily here, and it could be useful to look for hemophagocytosis, not always present, but more importantly, to look for malignancy as the cause of a sick patient. And as I mentioned, for CNS HLH, a lumbar puncture and brain MRI would be useful. Thankfully, the turnaround time for these tests are very quick. I want to talk a little bit about ferritin. This is a marker of hepatocyte and macrophage activation, which is, and is also a major intracellular ion storage protein. It's quite a sensitive marker for HLH, but not specific, meaning there are other reasons for a high ferritin, namely blood transfusions, stem cell transplant, renal impairment, liver impairment, malignancy, infection, hemoglobinopathies. So how do we use this ferritin if it's so good but so non-specific? There was a study from quite long ago which looked at the ferritin levels in patients coming to an ICU. And it showed that there are differences to the degree of high ferritin. If I can summarize it, or maybe I should show you this, the patients with HLH, as you can see, have much higher ferritins than other patients with shock, stem cell transplant, heart disease, etc. So perhaps a take-home number you can use is 10,000. In sepsis, ferritin may be high, anything from 200 to 1,000. In MAS and HLH, we're looking at numbers beyond 10,000. This I leave for you for reference also. What this table shows, if you're interested, is to explain why the lab parameters are seen. It's explaining the biology behind it. But I won't go into it so that we'll have a little bit more time for discussion of real-life cases. Here, again, for knowledge, is that there are other tests that can help us in deciding HLH. And these are, I suppose, the immune tests. Not always available for most of us. Even in Singapore, I do not have so much of these tests available, but they are useful, especially if you are thinking that this patient may have an underlying genetic or immune defect because they've had recurrent episodes of HLH. The important thing, remember, we want to keep this practical for you, is to look for the trigger. Remember the three big triggers: infection, rheumatologic, and malignancy. Infection, fairly easy, blood cultures, blood PCR, serology. Malignancy, again, I suppose fairly easy. But let me encourage you again, for rheumatology, it always boils down to a very careful history and examination. For patients who present very young or with recurrent HLH, consider genetic testing. So what does it matter what the cause is? It's because the pathophysiology can guide treatment decisions. We know that the endpoint is the same: uncontrolled, dysregulated immune activation, lots of cytokines. But in thinking about what is underlying that, we can somewhat choose better the medicines to use. In sepsis and inflammation, often the pathophysiology is innate immune activation, not so much T cell proliferation. If the underlying problem is a rheumatologic disease, then the problem is an already inflamed patient with an inflamed environment. And in these cases, the cytokines involved are IL-18 and gamma interferon. In patients with EBV-related HLH, there is very robust clonal T cell expansion. In primary HLH, remember I said the problem is often a genetic one with impaired cytotoxicity in the NK cells. In malignancy, the driver is different. The driver this time is the malignant cells and the body's immune response to it. Chemotherapy or CAR T, which is what I suppose we have in Singapore, the driver is different. In thinking about the drivers, you think a little harder about what you treat. And if sometimes that's difficult, you can think of treatment in terms of mechanism. If you want to target cell proliferation, steroids, etoposide, anti-ATG, and maybe cyclosporin. But if you think that I don't know which cell is involved, you just want to block the cytokines, then JAK inhibitors, anti-IL-1, and in some countries, anti-interferon gamma may be useful. I love to quote my pediatric oncologist, Prof. Kwa, on this. Even though I've presented for you the big picture of fire, I also encourage a little bit of finesse in fighting this fire. In secondary HLH, we're trying to cool the fire. We're not trying to kill a beast like in cancer. I'm going to take it that if a patient has a cancer as a trigger, they usually go to oncology. Yes, generally dexamethasone is like a panacea for any sort of fire. Just dump the water, lots of water, big fire. Etoposide, which the oncologist uses more, is focused on T cells. So there's a little bit more finesse than just dumping water. It's like aiming the hose at a fire because you think that the fire started at a certain point. And for patients with the T cell, or you suspect have a T cell trigger, anti-TG or anti-thymocyte globulin will be important. Cyclosporin is another useful drug for MAS with slightly slower action, but pretty good for maintenance or use for longer than a few days. Okay, so if the triggers matter to the treatment, how does it matter? For sepsis or infection, steroids, IVIG, anakinra, and of course, treat the infection. If there's an underlying rheumatologic disease, steroids are also useful, and maybe at a higher dose than you would give for infection. Anakinra, cyclosporin, maybe tocilizumab. For EBV related, I think in those cases, besides steroids, rituximab, JAK inhibitors are useful. For primary HLH, we will go with the HLH 94 or 2004 protocol. For malignancy, hand it to the oncologist. And for chemotherapy, it's stopping the chemo, treating the infection, and maybe anakinra and tocilizumab. Now, I'm not pulling this out of a hat. There is a very nice article that's very practical on how to treat HLH with some clues to the etiology. We call that context-specific treatment beyond steroids. This, again, I leave for your reference. In this article, they differentiated secondary HLH, meaning triggered by an infection, from MAS, meaning triggered by a rheumatologic cause. In both cases, steroids. But what is interesting, and I agree, is that in rheumatologic triggered HLH, the dose of steroids that they are recommending is higher, pulsing the patient. Whereas in infection triggered HLH, they recommended dexamethasone or a slightly lower dose of methylprednisolone. Again, just like with JIA guidelines, hold on to these guidelines lightly. More than exactly what steroid to use, what regimen, I think it is important to treat early, even if the patient doesn't meet criteria. And I will give you a case scenario at the end of my talk to show you this. Consider empiric immunomodulation if the patient in front of you has persistent, severe, or worsening inflammation. Even if the cause is unclear, you probably can start steroids, and if available, anakinra. By this time, your patient probably has started on antimicrobial therapy, and your cultures would have come back. If you are worried that there's ongoing infection, then it is also very safe to start some IVIG. You really don't have to follow HLH guidelines. If there is rapid response to treatment, reduce the treatment rapidly. If there is no response, add something else, layer by layer. How often? Maybe every 24 to 48 hours, depending on how sick the patient is. If the patient has very slow response, but some response to treatment, you can add other treatment, but reduce it much more slowly. And of course, if you think I'm just a general pediatrician, then refer to rheumatology or in your setting, immunology early. Remember, WTF. Whatever it takes, treat to target, and fast and furious. This is another article showing the types of doses you can use, and I'll leave it for your reference. I show this because one of the things Jayasri or Madam asked me was, hey, what dose do we use? What regimen do we use? DEXA or methylprednisolone or prednisolone? And what I want to show you is that there's a wide variety of guidelines. And instead of always following a certain guideline, it's to look at the patient in front of you and consider the process that's going on and how fast it is going on and treating accordingly. This I will also leave for your reference in terms of drug doses beyond steroids. This is one of the earlier articles from, I think, Wow, I cannot see anymore. Earlier articles from a few years ago, again, giving you doses. More than the dose, what I want to show you is that in the case of serious infection, anakinra is very, very safe. I know that you don't have that here yet, but one day, aspirationally, when it does come in, you can with confidence use anakinra even in the face of ongoing or severe sepsis. Other treatment options are as follows. And again, you will have no guidelines on exactly what to use in each situation. In some ways, that is the fun of rheumatology, being able to think about your patient and the process that's going on. Okay, let's say you've decided to treat, you've thrown steroids at the patient, you decided on some IVIG, maybe cyclosporin. Well, how fast do you expect response to therapy? In a very sick patient, assess them and the lab parameters every 12 hours. If they're not so sick, I think 24 hours is adequate. The assessment should be clinical, but also use your lab parameters as follows. If your treatment is working, the patient will stabilize in about 24 to 48 hours. And what you will see quite quickly is improvement in the ferritin, normalization of the temperature, and the organ dysfunction. Again, rapid response to treatment, rapid reduction. No response, add. Okay, let's say the patient is getting better. How long do you treat for? Treat until the inflammation is controlled. When unsure, just remove one medication at a time and reassess clinically and lab parameters. Think always about the trigger. The oncologist in my institution often says, some fires are everlasting flames. These would be the patients with primary or genetic HLH. And if this was the case in the patient, the only thing that will kill the flame would be a transplant. What about the very sick patient? Don't forget supportive care, including blood products, renal replacement therapy, ventilatory support, inotropes and vasopressors. And always treat the infection and look for infection, which may happen in the course of giving immunotherapy. Let me share with you a patient. I think I saw him last year. He's 16, and he came in with dengue shock syndrome. He already was confirmed on day 4 of dengue to have dengue. He had the classic fever, rash, nausea, lethargy, and his platelets were 90 on day 4. He had a positive dengue NS antigen, positive IgM, IgG. And because the platelets were not that high and he wasn't bleeding, he was sent home. But he came back on the 5th day because he was increasingly lethargic. He had worsening abdominal pain, which could be a sign of shock, more petechiae, and this time he was hypotensive. And in one day, his platelets had dropped from 90 to 12. He received fluid resuscitation, platelets, and FFP because he also had hematochezia. Here's the boy, admitted on day 5. On top is his temperature chart, and you can see that even on the 7th day, he was still hitting 40 degrees in his fever, and it wouldn't come down below 38.5. I'm quite sure you see quite a bit of dengue here, and it's a little bit unusual for someone with dengue to continue to have these raging fevers until the 7th day. More importantly, you see here that he also has worsening thrombocytopenia from 90 to 12 to 9. His hemoglobin was high, expected in a child who is hemoconcentrated, but his white blood cell count was, which is right here, was low. He also had worsening liver function with an ALT going from 46 to 195 and an AST, which is the SGOT, going from 96 to 500. This happened over the course of just 24 hours. So our ICU staff who are very in tune with HLH referred to oncology. Oncology looked at his PT, PTT, it was deranged. His ferritin was 33,000. This is definitely more than 10,000. And this is what they wrote in their notes. I really just copied it and cut it from the electronic medical records in my hospital. They wrote, day 7 dengue illness with ongoing inflammation. And I have to love them for this. They wrote, no need to fulfill criteria with dengue HLH. But in the absence of bicytopenia, this is, I think they meant in the presence, is less likely. Their argument, I love them for saying no criteria fulfilled, but they still did not think it was HLH because he did not have severe cytopenias. So their suggestion was continue supportive management, can consider starting steroids. Thankfully, in my hospital in pediatrics, we're all very good friends, and we often talk about our patients. I remember this was a Friday at 5 p.m., and the ICU intensivist came to me and said, I referred to oncology for HLH. They said it's not so bad, but can you take a look? What would you do? This smells like HLH, MAS, cytokine storm, doesn't really matter what you call it. Maybe you argue he's not that sick. Let's wait. But I'd like to ask, what are we waiting for? So he was referred to room. I said, okay, I'll see him. This is my long note, but let me just highlight what I wrote. I said, look, this is HLH. His inflammatory markers are super high with a ferritin of 33,000. He's got worsening transaminitis. He's not behaving like a dengue completely. Just treat him. I chose to give IV methylprednisolone 10 milligrams per kilo. Why did I choose that? I think it's really just a feel. Some of the other people here may have chosen 30, may have chosen 2. You know what? I'm going to say it probably doesn't matter. What matters is you assess the response. So this is him, right? I saw him that evening. I said, just give him methylpred of 10 milligrams per kilo. And his fever came right down and stayed down. You can also see that with the methylpred, just one dose, the platelets went from 30, 37, and doubled in 48 hours. The ferritin in 48 hours, 48 hours went from 33,000 to 27,000. And his AST, which went as high as 2,700. Took a while, but eventually came down to normal. Okay, how fast do you cut the steroids? Again, that is a matter of, in some ways, personal choice. But for him, knowing the trigger is very clearly dengue, knowing that he responded very, very quickly, I chose to reduce it quite quickly, and within 2 weeks, he was off steroids because he got well. Again, I am quite sure that the other rheumatologists here may say 2 weeks, that's a little bit long, whereas some may say 2 weeks, that's pretty fast. What I want to introduce to you is that there are variations to it, and the most important thing is to be able to track how your patient is doing. So in summary, HLH, MAS, cytokine storm, it's a spectrum of related diseases marked by hyperinflammation and organ dysfunction. Scoring tools do not replace clinical judgment. I will echo Som from Thailand who said, I don't memorize them. Maybe for her she doesn't need it, neither do I, and even if I did, I cannot memorize them. Ferritin is a good and readily available biomarker for MAS HLH. If you want to remember number 10,000, treat and refer quickly, calm the storm. Individualize the treatment, the type and the speed to the etiology, the trigger, and the severity of the patient in front of you. For secondary HLH and MAS, steroids, anakinra, easy. Collaboration and communication between the hospital pediatricians are important. As the general pediatrician, you are very important because we wouldn't get referred cases if you didn't think about it. And then after that, talking and discussion between rheum, hematology, oncology, infectious disease neurologists, hepatologists will only work if people will talk to each other. Treatment options continue to expand. I think later some of the doctors here will be presenting cases which are a lot more difficult than the one I have just presented, and I look forward to a discussion on that. Thank you very much.
Thank you, Professor Ann, for that very informative presentation. And probably we'll take the questions at the end. So we are going to have another 2 case discussion. And then we'll have a discussion, questions during the discussion. I think the most important word or phrase you mentioned in this presentation was diagnose early, and then you don't have to wait for and then start treatment before fulfilling the criteria. So that's, I think, very important message for all of us. Right, let me introduce the second speaker, Dr. Y. Nimal Raj. So he's a registered pediatric. I think we're going to present the clinical case scenario.
Good afternoon, all of you. I would like to present a case history of a patient who has managed at Ward 3B LRH with the patient concern. So I'll proceed with that case. So this is the name. She is Tishi Akia, 5-year and 4-month-old girl from Puttalam. She was admitted out of hospital, and she stayed for a long time. She was presented with the presenting complaints of fever, illness day 8, and itchy maculopapular urticaria rashes for 8 days, and multiple large joint pain for these 2 days. So regarding the fever, this day 1, she had a fever, but this non-documented fever. Following that, she had a fever free for the 5 days, and later the 2 days, she had a documented fever and presented to the hospital. Actually, regarding this itchy maculopapular rashes, it was started with fever illness on day 1. It was generalized rash, specifically not involved the palm and soles, no photosensitivities. Later, without fever, the severe urticarial rashes persisted, and this less response to the multiple antihistamine medications which started by GP. So those rashes persisted until that 29 of fever illness during the hospital stay as well. Regarding the joint pain, these are multiple large joint arthritis for last 2 days reported. Actually started with the right side angle joint, and following that there is a right side knee joint and bilateral elbow joint, and finally is persisted at left side angle joint and swelling, warmness as well. So arthralgia and myalgia she reported, and she had difficulty in walking, and no small joint involvement, no morning stiffness, no past medical history of joint pain. Otherwise, she was okay with the feeding, and urine output was good, and the bowel opening was normal. In addition, she had some concern in past medical history. Last 18 months, the child had the recurrent rhinitis, sneezing, and recurrent respiratory tract infection, and needed the nebulization 4 times in past. The trigger was for wheezing, cold, dust, and the viral upper respiratory tract infections noted. No exercise-induced wheezing, no family history of bronchial asthma. And she had persisted wheezing for last 6 weeks duration before presenting hospital. And the GP started the prophylactic medications, mid-dose inhaler, formoterol, budesonide, and antihistamine as well, these fexofenadine. On examination, child weight and height was the 75th to 90th percentile, and the BMI was 17.69 with that overweight. And she was very ill and febrile. There's no any cervical or generalized lymphadenopathy noted. And generalized maculopapular urticarial rashes we noted not involve the palm and soles. So the there's a multiple large joint pain and tenderness we have noted as shown in the picture. and it was tenderness, swelling, and redness, warmness, also with limited movements, no small joint involvement. Further examination, the abdomen soft with that there is no any hepatosplenomegaly. The lungs was clear, there is no any respiratory distress. Cardiovascular system, the pulse rate little bit tachycardia with that good volume pulse with the fever, but blood pressure was stable and there are no audible murmurs. And central nervous system, she had a limited gait because of this joint pain. Otherwise, there is no any focal neurological sign been noted. Problem on these admissions, we have noted there's a history of fever for day 8 and the multiple large joint for the last 2 days. With 6 weeks ago, she had some respiratory infections and urticarial maculopapular rashes for the 8 days and poorly responded to this multiple antihistamine. So initial our differential diagnosis, we thought about these possibilities of the reactive arthritis as she had this respiratory infection 6 weeks ago. And the fever at the moment, there are joint pain and rashes, possibilities of this mycoplasma infection. And we kept in our mind there are systemic onset juvenile idiopathic arthritis as well. So here, we see there's a fever chart. It's persisted for a while on this hospital stay. Initially, we have started with the treatment for the mycoplasma with clarithromycins, but we had done the mycoplasma antibody was negative. Thereafter, we thought about their fever, rash and joint pain persisted as there's a possibilities of typhus as well, and we have started doxycycline. This also is not responded, but this we have done the rickettsial antibodies that was negative. And the initial ultrasound scan we have done, that is there's no any hepatosplenomegaly, no any intra-abdominal masses found. So the fever continuously persisted. On the day 16 of illness, we have noted there is initial approach, we failed to manage this patient's fever and they have persisted joint pain and rashes. So at that point, as a fever chart, when we looked at, we thought about the possibilities of the systemic onset of juvenile idiopathic arthritis. But even though this diagnosis of Sogia is this exclusions of these other causes for pyroxia origin. So we wanted to investigate for the further causes for this pyroxia of an unknown origin. So we have started workup with that tuberculosis and MAR to test and bone marrow aspirate, gene expert was negative, and the CSF TB culture was pending. It's pending. So bone marrow TB culture was also pending. And CCT brain also we done. There is no any meningeal enhancements have been noted. And the sputum for AFP and gene expert was negative. And the mycoplasma rickettsial, I already mentioned that's negative. In further, the causes for this persistent fever, we have done a viral panel, HIV, and that was negative. And there's no recent evidence of this cytomegalovirus or EMV infections. And PAVO-V19 PCR is not detected, and hepatitis B, C surface antigens, antibody not, surface antigen not detected. And furthermore, we have done to screen for the typhoid fever as well, the presentation with rash and fever, and that was negative SAT. And melioidosis antibody was negative, and malaria parasite not detected in the peripheral blood film. And the toxoplasma antibody and toxocra antibody still pending, we not get report. And further, we have done a lumbar puncture that noted the polymorphs 10. Other than that, CSF glucose, protein, lactate was normal, and the CSF bacteria culture, fungal culture was no growth, and the CSF gene expert was negative. And at that moment, we have done the bone marrow aspiration and trephine biopsy as well. So that conclusions was reactive marrow, evidence of this increased hemophagocytic activity or the infiltrations by hemopoietic or the non-hemopoietic cells was seen in the marrow aspirate. So bone marrow culture for fungus and bacteria was negative. And the ANA we have repeated twice, that was negative. And rheumatic factor we have done, that was negative, and TSH T4 was normal. And 2D echo as well we have repeated twice to look for the evidence of infective endocarditis or any evidence of Kawasaki disease. And multiple blood culture and multiple urine culture we have done, all were negative, no growth. And the dengue antigen and antibody, we have screened for that, no evidence. And at that point, we have done the serum ferritin as well, that was 1735. But other HLH workup and investigation done, that all, everything was negative. So ultrasound scan, as I mentioned, that was normal KUB. And the CCT brain, no evidence of cerebral abscess also. The chest x-ray, there's no evidence of pneumonia or lymphadenopathy or mediastinal masses are noted. And blood picture we have done that shows suggestive of this bacterial infections, there's no any abnormal cells noted. So in between that, at ward, we wanted to treat this child with multiple broad spectrum antibiotic as I shown in this fever chart, initially with penicillin and clarithromycin and IV comoxiclav, following that this doxycycline, and we started this IV meropenem as well. But even though there is no any improvement, we have noted in the fever rash with persistent large joint pain. So in the fever day 29, in the latter part of this fever, we can note it here. So latter part of the fever, the child newly developed, there is sore throat and this cough with that multiple cervical lymph nodes. It was initially was less than 1 centimeter, but following the days, it has increased the size to 1.5 to 1 centimeter, but there is no generalized lymphadenopathy have been noted. And that day we have done a full blood count that shows there is a serum ferritin came down, that is 460, but we have noted there is some cytopenia, there is the reductions of this WBC count and platelet count we have noted from the baseline. Furthermore, for the sore throat as cough, and we wanted to screen for this influenza A and B. That was the real-time rapid antigen test was negative, and throat swab culture, there is no any organism isolated. And as the large lymph node, we plan to go for there is a lymph node biopsy. But here you can note there is from day 29 to day 32, there is this, the high spiking remittent fever. We have noted this not came to the baseline. So during that period, we have noted the child get more illness and critically was ill, and the high spiking fever, and the full blood count shows there is a cytopenia. And the ESR dropped from the 84 to 42, and the CRP increased 35 to 64, and developed newly the proteinuria with the UPCR 225, and elevated renal and liver functions as well. And furthermore, we have done, even though in the clinically not palpable splenomegaly, we have done ultrasound scans. We have detected there is a mild splenomegaly with bilateral enlarged kidney with increased echogenicity due to the possible of acute kidney injury. As we have detected the lymph nodes, we done ultrasound scan as well. That shows they are suggestive of this is reactive lymphadenopathy. It's not suspicious. Chest X-ray was normal. The lymph node biopsy we planned, but withheld due to the instability of the patients and this low platelet after discussion with surgical team. So further blood investigations we have done. So at that point, we have noted because of this remittent fever, with that the child critically getting ill. So we thought about the possibilities of macrophage activation syndrome or hemophagocytic lymphohistiocytosis. So here in the trend of this full blood count, we can see initially there was this full blood count in the baseline with that 13,900. So initial with the starting of this high spike of fever here, it started to this 5,640. At that time neutrophil was 4,300. And following that day, we with that high fever spike, the WBC started to drop with 3.41, the 3,410, with at the neutrophil drop to here 1,240 as well. So we have noted the trend here. There is sudden drop of the cytopenia. Furthermore, this is the platelet as well. So I show in this green color, they started to drop. And look at the serum ferritin of trend. Initially, it was this 1,735. After that, slowly progress come down and came to that 460 on that day 29. And there is a following that day 32, the sudden rise of the serum ferritin, we have noted 1,000 331. With that, we have noted this ESR sudden drop from 84 to 42. And furthermore, in the liver functions, it started to raise up suddenly here. Suddenly from 500, from this baseline to this 581 as well. So, at this point, we have noted there is the ongoing fever spike and newly appeared splenomegaly with cytopenia affect all the cell lines with hypofibrinogenemia. It was 1.13 with elevated TG level and hyperferritinemia, and it complicated with acute kidney injury and acute liver injury. So, we have diagnosed clinical and biochemically there's a chemophagocytic lymphohistiocytosis. So following that, this the diagnosis of this HLH, we started immediate management with at IV methylprednisolone, 30 milligram per kg, pulse doses. Combined together with that, we started this cyclosporine, 5 milligram per kg as a dose recommended, 3 milligram to 7 milligram. We have started with 5 milligram per kg. And further severe neutropenia, we have started, there is the infections preventions with the barrier nursing care. And this broad spectrum antibiotic, we have started teicoplanin and IV ciprofloxacin as well. So following the day, we have continued the second dose of IV methylprednisolone here. And following that, we have serially monitor the full blood count and the serum ferritin as well. On the third day, we have done there is a full blood count and a serum ferritin, and we have noted there is this there were the persistent severe neutropenia and worsening we have noted with that 390 neutrophils. With that, there's a serum ferritin was static on that 1331 and 1319. So we thought about there is this less response for steroid, and furthermore, but at that time, we have noted the fever started to settle here. But even though we had an urgent multidisciplinary team meeting involved, the pediatricians, rheumatologist, hematologist, and transfusion physician together had an urgent meeting, and we had a further plan for this further management of poorly responding HLH. So we have decided to go for this plasma paralysis or plasma exchange. Because of this is the superior to the steroid as well as the faster than the actions in this faster than the steroids as well. So we have planned for this plasma exchange. While on the way, we have started, there is a IV immunoglobulin, 2 gram per kg infusions during that night time. And furthermore, severe neutropenia, we had discussions and we have decided to start GCSF subcut, there's 5 mics per kg as well. And furthermore, the second day, following that day, we have completed this fourth dose of IV methylprednisolone and started the first cycle of plasma exchange as well. So following that, we have continued that next day the fifth dose of this IV methylprednisolone, and following that day we have continued this second cycles of this plasma paralysis. With that, we have converted these prednisolones to oral 2 milligram per kg, and we continue the cyclosporine as well. That day, we have repeat the bone marrow biopsy that shows the hypocellular marrow with a markedly suppressed granulopoiesis and evidence of increased histiocytic activity suggestive of HLH. So following that days, we have continue this prednisolone and cyclosporine. With that, we wanted to continue after discussions with the rheumatologist and the hematologist to continue the GCSF because of persistent neutropenia and high risk of infections. We continue the GCSF 5 mics per kg for 10 days, following that the period of day 38 to day 43. And at the end of the 10 days, we have noted there is the increased WBC rise up in the trend. I can show here in the trend, the following the end of this GCSF, we started the WBC very quickly goes up to that 3,600 suddenly. During that time, we have repeated serum ferritin as well. That also has increased. It's 1,603. This compared with that initial, this very high for us. So we thought about that. In addition, so we have done an ESR that from this initially it was around 39. It dropped to that 13 as well. So we have thought about there's the possibilities of macrophage activations at that point because of this elevated serum ferritin. But the child clinically was well. There is no any fever. Even though we have decided to start this IV immunoglobulin 2 gram per kg, we have continued to infused and finish that. The following that we have monitored the child full blood count serially and the serum ferritin serially. It came down slowly. On this following this other 1 week, it came down. There's reasons we decided to discharge the child with that prednisolone 25 day morning and 5 milligram nocti with cyclosporin with infection preventions and the monitoring of steroid side effect. And we have planned to review in 1 week time. So furthermore, we have reviewed the child in the 1 week and we have repeated all the investigations, full blood count, ferritin, triglyceride, fibrinogen, and the ESR, ALT, and the renal function and the liver functions all came back to that baselines. So we have planned to tail off the prednisolones since this last week, and we will continue the cyclosporin and plan the review on the next 2 weeks time. So hopefully the child will come back to us in this next week for further investigations and this monitoring of this disease activity. And we have advised to that the infections prevention and the side effect of the prednisolone as well. So this is the happiness behind the success of our treatment for the child as well as for. I would like to thank to this resource teams to give an opportunity to present this case. Thank you.
Thank you, Raj, for your excellent case presentation and especially for the keeping your time. So let me introduce now. We have a time for the discussion. Let me invite Professor Ang to the stage. Yeah. And what about Animal Raj? It's okay? Yeah. Yeah. I'm sure our audience must be having enough questions. Now we had a diagnostic and management dilemma whenever we get a patient with either HLH or MAS. This case is open for discussion. If you have any question, you can ask.
As you're thinking about that, may I make some comments? First of all, thank you very much for the presentation. It was a very complex case and you presented it so clearly with all the details, which I really appreciate. I think the biggest question is, what's the trigger? What's the trigger for this patient's MAS? I hope one of the take-home messages from my talk is, in thinking about the trigger, we can think more about likelihood of recurrence, how quickly we're going to reduce the steroids or other things. I think it was very sharp that once you saw the counts dropping, you started thinking about MAS. But what do you think was going on for the first 30 days?
We have answered to that. The only thing positive was hepatitis B. That's probably the following vaccination, I suppose. So only thing positive, the investigation was hepatitis B antibody, serology. Probably the second to the vaccination, I suppose.
I mean, I must say, because you presented it so well, I honestly thought that at the beginning that this child has systemic JIA, right? High spiking quotidian fevers, arthritis, which you also presented, and then a rash. Now, the rash in SJIA typically fleeting, itchy, which was the case. I cannot remember how fleeting this patient's rash was. And so that was my thought, that this child had SJIA. And I wonder if that is or was the trigger for her. I think when I looked at all the investigations that you can do, I'm very impressed at how much you can do here. Maybe my encouragement is, if you start antibiotics, right, I could see 5 days of Clarithril, 5 days of Doxy, 7 days or something, and 7 days of meropenem. The good thing about having so many tests that you have is if you don't have evidence of infection, either on serology or blood cultures, and if after 48 to 72 hours of an antibiotic it's not working, you can probably switch antibiotics or even stop the antibiotics and move on to thinking about an alternative non-infectious diagnosis. I think that thinking about the first 30 days is really important.
I think I really congratulate the person who presented the case. It was very, very nicely done, and I could see the team spirit in treating this case when he was presenting it. Few things from my side, like Elizabeth said, I would agree that it strikes you that possibly this is a systemic JIA. It would have been useful to know if the rash was evanescent or fixed, because when in systemic JIA, in the active systemic phase of disease, the rash is often evanescent. It can sometimes be an urticarial evanescent rash, which is itchy. Subsequently, when it goes into the macrophage activation phase, which is basically just increased inflammation of systemic JIA, it's just one end of the spectrum of the inflammation in systemic JIA. At that point, it becomes a fixed, a maculopapular, extensive, almost measles-like rash in many patients. What helps from my point of view for these patients is looking at the trend of investigations. When he showed that chart, between day 9 and 10, there's a drop of the white blood cell count from 13,000 to 5,000. I would have really liked to know what the platelet count drop was at the same time. I think that's the point when HLH has definitely struck. That's what it seemed to me. So one of the things I think for pediatricians is to think that when a child's fever is not responding, think of non-infectious causes. Can this be a non-infectious cause of fever? That awareness should come first, and then you start thinking, if a non-infectious cause of fever, what cause could it be? And of course, you have to think about malignancy. Dr. Ang showed a whole list of conditions where you can get HLH. And let me tell you, malignancies can be very deceptive. So leukemia, for instance, is a little easier to pick up on your bone marrow if you do it early enough. But a patient with a lymphoma may not have bone marrow evidence. And many times these patients may need imaging and then an appropriate biopsy to make the diagnosis. And once you give them steroids, that lymphoma melts, and then it takes a much longer time to make a diagnosis. So these things have to go through your mind. And in the afternoon, Dr. Suleiman will be talking about SLE, which is another cause, fever, rash that can go into MAS. So there are many non-infectious causes of MAS. So 2 thoughts regarding HLH. First, is it HLH? Second, is it primary or secondary? Primary usually hits you in infancy, though it can present for the first time even in older children. And if it's secondary, what is a trigger? Because this is what you need to know how to treat the patient, what approach would be the best.
Thank you. Probably I have nothing to add much, but again, I congratulate you for the nice presentation and the outcome of this patient so far. Probably if this patient presented to pediatric rheumatologists, they will agree this is most probably systemic JIA with MAS. I agree with Professor Sommer. Some cases of systemic JIA present with urticarial rash. not necessarily the usual or typical rash. With this extensive workup, I believe this is the case until proof otherwise. I don't think hepatitis B will explain the case. Now, one of the differential diagnoses which may be difficult to prove it in certain conditions, which is interleukin 18 associated hyperferritinemia, and they may present similar to systemic GIA, and they're the only way to prove it by checking the interleukin 18 level. And we have cases, probably they present similar to your case. They have recurrent MAS. As we taper the steroid, they flare, and actually we treat them with anakinra. But as we wean and stop the medication, they flare till we decide to check for that interleukin and to be high. And now we are treating them differently.
Oh.
I'm not sure if we need to comment about the treatment approach or...
Yeah, I wanted to ask, when I sit back and watch what was, it clearly shows the panic reaction, We waited for 3 days, but in real life, that is what happens. The child does not respond. We go for the next and next and next. And one thing I was arguing against is giving that, colony stimulators. When the thing was rising, I told the hematology people, now we don't need this. It will go exponentially high, and that will increase the ferritin level again as well. So I just would like your comment on that. Because we are in a team, we sometimes need to give in to the other one, yeah?
Well, regarding the GSSF, usually we don't use it unless there is documented infection. And as per ID protocol and pharmacy, they will not allow us to use it unless there is documented infection. In such case, probably you don't need to, because this will mask and change the real presentation. Now, you did very well with using high dose of steroid, but probably in my case, I will advance the treatment. I will initiate the combined treatment early on. I'm not sure what is I have only one concern using plasma exchange in his case, especially after giving IVIG and the steroid. We know this will wash out the treatment.
Yeah.
So probably I will not consider plasma exchange in such case. I will just keep giving high dose of steroid. I will not limit myself with 5 days. I will keep, as far as there is improvement, I will keep them on higher dose of steroid, cyclosporine, IVIG, all these. And probably I will call in certain condition, if I don't have IL-1 blockade, I will call hematologist to use hepatocide.
Yes, I think we actually presented a paper once with limited use of etoposide in these patients. You don't have to go to the entire HLH protocol and give it to them for 12 weeks or whatever. You can give 2 doses and turn around the HLH and stop there and continue the maintenance with steroids and cyclosporine. That's fine. GCSF, the problem is that it can activate the macrophages and cause a problem round robin again.
We could have stopped it earlier in this case. Yeah. It went a little beyond, I think.
The one more tip is that when you have a patient with HLH who's responding to the therapy and then becomes febrile again with significantly dropped counts, think about CMV reactivation. We've had about 4 or 5 patients with this story. We check a CMV PCR and it's high, and all you have to do is treat the CMV. So this infection inflammation is a cycle that feeds on itself. So think of the various possibilities that can happen.
Yeah, I think in this patient, again, I'm going to always ask, right, what do we think is the trigger? So I think in the first 30 days, SJIE, I think another thing that can look so sick with bad HLH like that in the Asia region is EBV. Some of the sickest HLHs I've seen are those with EBV. But I think for you all, you managed to do the EBV studies, which ruled it out. I think plasma exchange always feels good when we're desperate, because it doesn't quite immunosuppress the patient. It removes whatever circulating cytokines there are. And I suppose as a kind of like trying to save it, it feels okay. But another option besides low-dose etoposide, not following HLH protocol in this patient, might actually be JAK inhibitors as well. The studies, or the ongoing study, is for ruxolitinib, but I don't see a reason why any other JAK inhibitor will not work. I don't see a reason why it will not work. So if you have tofacitinib, I think that's an option for a patient who has MAS that you don't seem to be able to control with steroids, IVIG, cyclosporin. In thinking about the trigger for this case, I think my guess is maybe an underlying SJIA, and therefore in weaning or reducing the immunosuppression, I might keep cyclosporin on while I taper his steroids.
I think you answered my two questions. My question was that the place of plasma exchange. In your management plan, you never mentioned about the plasma exchange. And yeah, I know. I mean, in condition, situation in Sri Lanka, our hands are very tight. Sometimes we don't have all the options available. So in that case, what do you think? Is it a good thing, or should we defer it? Other thing regarding the etoposide, is there any superiority of giving IV or oral? It should be IV. Right.
So again, plasma exchange, you are not alone as a country using that as, I suppose, it's like oh my goodness, trying to save something. In Vietnam, or Philippines, they do hemoperfusion, kind of the same mechanism. But it's really a stopgap measure, right? It definitely does not target the underlying process. It's like the cytokines, I wash it out, but it doesn't stop the process.
Yeah.
And then for such a sick patient, definitely IV etoposide. In my slides, I wrote the dose. It's much lower than you would use for primary HLH.
Yeah. We'll talk about share experience about plasma exchange after the next case. Otherwise, we'll run out of time. Yeah.
Yeah, let me introduce the next speaker, Dr. Diniti Rupasinghe. He's a senior registrar in rheumatology and rehabilitation.
Good afternoon all, and thank you for giving me this wonderful opportunity to present in front of this esteemed gathering. So today, discussing about this macrophage activating syndrome, the unmasking the hidden burden. So it's a case-based discussion. So moving on to our patient, she is Miss S, 13-year-old schoolgirl from Ampara, who has initially presented with intermittent, prolonged fever, inflammatory type joint pain involving proximal and distal interphalangeal joints, progressive shortness of breath on exertion, photosensitive facial rash, and constitutional symptoms for 4 months to District General Hospital, Ampara. Further into her history, she did not have any altered bladder bowel habits, chronic cough, no postural symptoms or skin pigmentation, no bleeding manifestations or pruritus, and did not have any history of TB contact, traveling to malaria endemic areas, recent foreign travel or high-risk sexual behaviors, no history of substance abuse, and she did not have any significant past medical history, and had a good family support, and she was a schooling child who studies at grade 7. So initial investigations done in her presentation to Ampara Hospital, her full blood count, the WBC revealed 4.6 with marginal lymphopenia, then HB of 9.5, and platelet was 139. And the blood picture revealed pancytopenia, which revealed further evaluation. And the ESR was 21 with a CRP of less than 6. And the clotting profile was normal. The liver function was initially normal except for hyperalbuminemia. In her urinary full report, there was no dysmorphic cells except for trace albumin. And the serum creatinine was within the normal range for her age. and the ultrasound scan abdomen with the kidney urinary bladder as a normal study. So, however, after excluding the possible causes for this prolonged fever, mainly the common cause for the infections and inflammation and other malignant conditions, so they have proceeded with the autoimmune panel, and then the ANA came as positive with 1 in 320 with nuclear homogeneous pattern, and the dsDNA and the APLS screening has been negative. So, with that, according to the EULA ACR 2019 criteria, this patient had a positive ANA with fever, subacute cutaneous lupus, with an evidence of serositis like pericardial effusion, and the hematological involvement with initially leukopenia and thrombocytopenia, which later went into pancytopenia, and cerebral involvement with seizures and synovitis involving more than 2 joints. So then, according to the classification criteria, she had fulfilled a score of more than 10. So with that, the initial diagnosis was made as severe SLE flare with cutaneous, musculoskeletal, serosal, renal, and neurological and hematological involvement. So with that, they have commenced treatment with HCQ 100 milligrams daily and started on methylprednisolone pulses, 30 milligram per kilogram daily doses with the cover of broad spectrum antibiotics. However, while on this treatment, there was a new development during ward stay. She has had progressive deterioration of clinical features, including development of low GCS along with fits, and persisting fever, tachycardia, tachypnea with oxygen dependency. So what could be the reason? So this is the fever chart, which is from Ampara. So you can see after her admission, now her fever has been persisting. It has been a continuous fever. So in summary, at the peripheral hospital, she has had intermittent fever with inflammatory type joint pain, serositis involving pericardial effusion, and the cutaneous manifestations with malar rash, oral ulcers, non-scarring alopecia, and a discoid rash, with neuropsychiatric manifestations with the fits without behavioral changes, hematological manifestations with pancytopenia, and subnephrotic range proteinuria. So, with the management, with the severe SLE flare with deteriorating clinical features, she was later transferred to Lake Ridgeway Hospital for Children for further management because she has had this continuous fever with rising transaminitis and the persistent cytopenia despite high-dose steroid therapy, and the pericarditis with thin rim of pericardial effusion and organizing pneumonia on imaging, which is evident in the HRCT chest. So on examination on admission to LRH, in this image, you can see that acutely ill patient who was bedbound with oxygen dependency. So she was febrile and was very ill, and she was pale but not icteric, and she has had evidence of non-scarring alopecia, oral ulcers, and a discoid rash. So in the systemic examination, her cardiovascular system, she was tachycardic with low volume, and blood pressure was maintaining around 116/85, and a dual rhythm was present without any added sounds. On respiratory examination, she was tachypneic with a respiratory rate of 40, and the saturation was maintaining on 98% with high flow nasal oxygen for 40 liters per minute, and she has had bilateral crepitations, mainly in the left side. And however, on admission, she had the GCS was 15 out of 15 without focal neurological signs, but had tender hepatomegaly without any free fluid, and there was evidence of synovitis involving bilateral proximal, distal interphalangeals, and as well as the wrist joint and the elbows. So we were thinking whether it is macrophage activating syndrome with autoimmunity with the given background and the acute deterioration. So on admission to the Lake Ridgeway Hospital, there was evidence of cytopenias with WBC was 4.6 despite high dose of steroids with an HB of 9.6 and the platelets 139. The ESR was 70 with a CRP of less than 6, and she has had very high serum ferritin. It was more than 38,000. And there was evidence of transaminitis with AST of 261 and ALT was 74. And the fibrinogen level was 5.1. And the non-contrast CT of brain, there's evidence of diffuse cerebral atrophy. So with the persisting fever, cytopenias, hyperferritinemia and transaminitis with imaging findings consisting with an inflammation with pericarditis and organizing pneumonia. So we've started treatment as per the HLH because this is a life-threatening condition, an emergency. So with the involvement of the multidisciplinary team in the course, so we've started treatment with controlling the storm and along with the modifying disease activity and as well as with the supportive care involving airway management, pressure point care, bladder bowel care, nutrition and as well as with the diabetes prophylaxis. So the management for the controlling storm, we've continued with the IV methylprednisolone 30 mg per kilogram day for further 2 days for the total of 5 days. And along with that, we have started with cyclosporine 50 milligrams twice daily dosing. And since there's an underlying autoimmunity along with very high ferritin levels with severe disease flare, we've arranged an urgent plasma exchange. So on admission within hours, the patient underwent plasma exchange. So at the same time, we've continued the supportive care as well. So in this slide, as you can see, on the very first day, the serum ferritin levels was very high, more than, it's around 38,000. So the patient underwent a plasma exchange, and as the days goes on, her ferritin levels went down, and we've continued with the IV methylprednisolone, and later was started off with oral prednisolone 2 milligrams per kilogram dose with HCQ, and we continued with the oral cyclosporine as well. So on day 1 for the admission to the LRH and as well as on the day 3, the patient underwent plasma exchange. And due to this underlying autoimmunity with SLE and severe organ involvement, the patient was treated with IV cyclophosphamide pulse. And then also after 2 days, then again another plasma exchange because the patient has a severe disease manifestations and acutely ill. And with that, and there was a place for the oral etoposide as well within 9 to 10 days of the admission. And this chart shows how her hematological parameters changed over time. And this is the fever, the continuous fever where she has had when she was transferred from the peripheral hospital. And at that time she has had severe lymphopenia, and as well as the platelet count was more towards in a dropping trend. And the WBC was maintaining around 4,000 with even with the treatment with high dose of steroids. And with the initial management along with plasma exchange and as well as the IV cyclophosphamide, this is how the patient's fever spikes responded. At this point, the admission to the LRH, and then at this particular day, the patient underwent plasma exchange, and she has had, in fever-wise, the fever was settling with the initial management. And as well as the clinical parameters were also improving. And this chart shows how the parameters change over the time. And this is on the very first day with high serum ferritin and with the low WBC level on admission. So, and then it changed over time. And this is how her platelet went off. And when she was coming in, she has had high ALT levels. And with the initial management, it was also coming down to for the normal ranges. But however, while she was receiving this immunosuppressive therapy for the controlling storm as well as for the disease activity, again she has had high serum ferritin levels with marginal lymphopenia. So we were thinking, what are the possibilities? Why there was a sudden deterioration while the patient was on this current treatment? Because she has had very high fever, low blood pressure, and tachycardia with respiratory distress. So at that point, we managed the patient with septic shock because her procalcitonin levels came as 22.2, which is very high. And then she was transferred to medical intensive care unit for further management, where she has been intubated and ventilated. The differentials that we had for the acute deterioration was whether it's an acute infection due to immune suppressive state, or whether it is acute interstitial pneumonitis because she has had underlying SLE, and whether it is diffuse alveolar hemorrhage or heart failure due to myocarditis. So after excluding the possibilities, the patient had these worsening lung feature findings, the new development of bilateral progressive inflammatory shadows, and this is her HRCT chest, which shows progressive changes. And she underwent 2D repeat UD echo and also for the septic screening as well. So at that point, her COVID-19 PCR came as positive, and then she was treated as per the for the COVID pneumonia with the remdesivir and as well for 7 days, and we've continued with the prednisolone and HCQ at the same time. So this chart shows, so initial on admission she has had very high serum ferritin levels, and then with the initial plasma exchange, cyclophosphamide and short course of etoposide, the patient, the ferritin levels are responding, and there was with the sudden deterioration, the ferritin levels was again rising for around 12,000, and then due to the this underlying SLE and the COVID pneumonia, it would be in a trigger for the again for activation of for this cytokine storm. So we need to treat urgently. So the patient was treated with IV immunoglobulin 2 gram per kilogram, and so with that the patient the ferritin level starts to drop. And so in this summary chart of investigation, it shows how her in hematological and as well as the infective markers and the ferritin has dropped over the time course with the acute management. So in this chart, in the summary, the hematological parameters is how her platelets were initially had a dropping trend, and with the management, the platelets are going up. And then the WBC was slowly picking up, and the initial the continuous fever was responding for the plasma exchange, cyclophosphamide, and the acute deterioration due to COVID pneumonia, and there was a continuous fever with an impending mass, and then with the acute interventions, the patients again the responses there. The serum ferritin, how the serum ferritin changed over the disease course. So, as for the long-term management, once she has came out of the acute condition, so we decided to continue with IV rituximab 375 milligrams per square meter weekly, 4 doses, because of the underlying autoimmunity with this SLE, and as well as for the further management of the macrophage activation, and we continued with the same treatment, and later on for the tailing off of prednisolone, and we'll continue in the HCQ. So after acute illness, this is how our patient was seeming very happily, and was retransferred to Ampara Hospital for the continuation of treatment. So the key points from this case would be the early identification of the cytokine storm, and to timely transfer for the specialized care or the seeking for the specialized care early in the disease course, and the timely intervention with the management, and the aggressive treatment to control the storm. So this is the medical team who involved in managing this patient day and night. So a big thanks to the whole medical team, and that's why we were able to manage this girl and was safely sent home and was transferred to Ampara. So thank you very much.
Thank you, Dinti, for that presentation. Once again, let me invite all the speakers, guest speakers, to the stage for the discussion, please. If the audience has any question, you can ask.
I think we must discuss about this plasma exchange business and share experience that what we have seen, isn't it, Rasika? There had been, in my learning curve, first I did not know what was happening. First, the patient died. Rasika and myself, we looked after, but before I make out what was happening, the patient died. So, as you said, Liz, earlier, when the general pediatricians and generalists don't know how to diagnose and identify macrophage activation, it's such a scary thought that I have worked 9 years in the periphery as a consultant rheumatologist. I have never seen a case. I have read about it, I was scared about macrophage, but I have never seen a case. So it's the primary carers who should think of it and refer. Without seeing one, my theory knowledge is of no good, And then I had this learning curve, and I tried my hands on various things. I learned from the failed cases, and I learned how to manipulate methylprednisolone, then etoposide. As you said, we have had a very good oncologist who would, tell us oral etoposides for 3 days, and we stop, watch what happens, and then the next week we decide to give or not to give. That was beautifully managed. And then there were these timings that I thought it was about 2 patients died. I was too close to the hitting point of the storm. And then on one such case, I was reading about, this all the time. So I tried. One day, this girl came to almost the verge of collapsing. Once, how when a child collapses with macrophage activation, they might live in ICU for 2 weeks but still die after the bleeding point. When they start bleeding, I never retrieved a patient like that. I don't know your experience. So this child, she had a fit, she was tachycardic, and then I knew I have to try this because I have tried methylprednisolone, I have tried etoposide. The child was on cyclophosphamide and etoposide together, and then there was cytopenias on top of cyclo and etoposide both. You cannot give it anymore. Then I was optionless, and then I tried plasma exchange, and this girl survived. So that was how I started using plasma exchange after 4 or 5 years into my experience with macrophage. So then I have found, I have experienced that that's the quickest thing to come out of the danger. But it does not, you have to treat the underlying cause. It does not anchor, you need to anchor the underlying cause. So what I have learned was this Salakshika, this girl, Liz knows this one because it was unfolding when Liz was communicating with me. So when she came with tachycardia, they are clinically relatively good. There's silence before the storm. You could never know what will happen in the next hour. But generally they are tachycardic. They are very tachycardic just before the storm hits. So she was, tachycardic, tachypnic. I thought there's no time to lose because the consultant from Ampara just told me that she was coming, and I knew she landed. I wanted her to land in his ward, so we manipulated that a bit. So I thought I can't wait because he already has had methylprednisolone, 3 pulse already. So that's why I chose to do plasma exchange at that stage. So that was my experience. So I don't know. Maybe I'm panicking.
I think this was a very sick kid. It's easy for us to sit here and listen to it on hindsight, but while you're managing her day to day, I'm sure it is very, very scary. I think I'll speak to the non-rheumatologists here. If you can send these patients to Madam Jayatri earlier, they may not need, right? They may not need plasma exchange. By the time they become so sick with ongoing infection, I think plasma exchange is reasonable. Is reasonable.
That's the quickest to act, but it doesn't last. And you had to juggle your cyclophosphamide, methylprednisolone, space it, not allowing it to, it is, otherwise it'll be washed off, and you had to time it. And the most problematic thing was inserting the, Rasika has experienced, inserting the Vascath. They're almost in the verge of bleeding. You have to, if you delay, it will bleed the child to death. We had one case, and one case the child swelled up, but he survived. We had one case but it entered the pleural cavity for some mistake also. I don't know whether that was purely due to the bleeding. That was a complicated, cannulation also. So that was my experience. I don't know.
This was definitely a sick child. She had multisystem lupus, that was obvious, and MAS. The subnephrotic proteinuria does not rule out proliferative lupus nephritis. I'm sure she had one. She was too sick to undergo renal biopsy for sure. But I think the diagnosis was pretty obvious quite early on, and that's really, I think, the purpose of this entire thing, to sensitize pediatricians to picking up this diagnosis early. When you give 3 days of pulse, I'm sure there would be some improvement. The child would have, the fever would have, reduced a bit, the counts would have picked up a bit, and that doesn't mean that you stop with 3 days. You can give a lower pulse the next few days. You can always give a bit more. You can give IVIG, would be a very useful drug at this point, and actually hitting the lupus with cyclophosphamide very early on would have been my choice, which might have arrested the entire process. The other thing about procalcitonin, we should not have a unidimensional view that procalcitonin always picks up sepsis. We've just published, we did a study on procalcitonin in systemic JIA to see whether it would help us differentiate between a flare due to systemic disease and a flare due to infection. And what we found was that it did not differentiate at all. The second thing we found was the highest levels of procalcitonin were seen in macrophage activation. Off the charts, above 75, above 100, always more than sepsis, highest in macrophage activation. So that is another thing to think. It may not necessarily be, may not necessarily mean that it's a septic process that is affecting the patient. You'll have to be there and judge the situation. It's easy to sit here and say. That's, of course, very, very true.
Well, I am not a plasma exchange fan. I don't use it. We probably use it for a few patients. And all the time when you decide to use it, the patient already on intensive treatment. So you don't know which one is working. Now, this patient in particular is SLE, and we know SLE is immune complex mediated. So maybe plasma exchange work, while the first case will not work because that one was systemic GIA, different pathology, different underlying mechanism. The major concern for me in plasma exchange all the time, you need to tailor it and time it with the medication, otherwise it will be useless, and the medication you give will be useless because you will wash it out. And recently, I just came from ACR, even for the ANCA-associated vasculitis, which is the main indication for plasma exchange, now they don't believe in it that strong like before. So they are a bit relaxed using plasma exchange. Definitely, this is a sick patient. You will use everything in your hands. Nobody who will say that wrong, but retrospectively, plasma exchange probably it will not be one of the options, at least in my book. I can see, at least from the nice presentation present, the serum ferritin started drop in after the IV methylbret, even before using plasma exchange. Now, the main message I will get from this case, all the time you need to look for triggers infection. And the reason for deterioration and second admission to PICU or MICU because of the COVID infection.
Yeah. And about the ferritin level, once when you do plasma exchange, you lose the ability to monitor it with ferritin level. So you can't go by that. You have to go by other parameters. So that's the other thing. When you do plasma exchange, you have to know that your ferritin level is not going to show the disease anymore in the way it should show. Yeah. It makes it difficult.
Yeah, thanks for making that point. So I hope, even though we say HLH, MAS, cytokine storm, the name doesn't matter, you treat the inflammation. But what matters is the name of the trigger. In this case, I would say that her diagnosis is SLE, maybe with CNS lupus, most likely with lupus nephritis, triggering the MAS. And this is important because once the MAS is over, she needs to be treated for her lupus, probably lupus nephritis, maybe CNS lupus, and that could take the form of cyclophosphamide or at least MMF. If not, she could go into MAS again.
May I say something? Sure. So
Yeah, let me ask one. Yeah, but are the main, when you are going to monitor the child for the improvement or deterioration, what are the factors you are going to monitor actually?
So when you start treating HLH and you give that IV pulse methylpred, the first thing you'll see, same day or next day, reduction in the fever and improvement in the encephalopathy. Those are the first two things you see. You may see beginning of stabilization of counts, may not improve. They might actually not worsen. That might be the first thing you see. Platelet count is the first thing, then your WBC count, and only finally your hemoglobin. Because that's the way they're generated in the marrow and that's their half-life. So that is the way, and then you will see the other things, the transaminases settle, then the ferritin goes up exponentially, comes down exponentially. So that is another thing that you can use. So it's all, the lab parameters lag behind the clinical improvement. That's what we tend to see.
Agree. If I had to choose one lab parameter that could change in 24 hours, it would be the CRP, given the half-life of CRP, and then maybe the platelets for the first 24 hours.
Yeah, thank you very much for that excellent discussion that we all learned. Because we had clinical and then diagnostic dilemma as well as the management dilemma. So thank you very much for sharing your thoughts with us. Thank you, ma'am. Let me invite all the guests and the audience for the lunch, I think, which lunch is provided.
Just a small thing before lunch. So to present 3 small tokens of appreciation on behalf of the respective colleges to our distinguished academia panel for today. I would like to cordially invite Dr. Paediatric Rheumatology, President of the College of Specialists in Rheumatology and Rehabilitation, to present the token of appreciation to Professor Elizabeth Ang. To present the token of appreciation to Professor Suma Balan, I cordially invite Senior Consultant Pediatrician Dr. Rasika Gunapala to come on stage, please. Thank you. To present the final token to Professor Al Mayuf, I cordially invite Senior Consultant in Rheumatology and Rehabilitation, Dr. Dumida Munidas, to come on stage, please. So thank you so much to everyone. So that concludes our session 1 for today. Lunch will be provided outside, and I would kindly ask for your cooperation. That will be in the ground level, and I would kindly ask for your cooperation in being back here at the same hall at around 2 o'clock to start the next session, please. Thanks.